Hello.
Yes.
Well, good morning, everybody. It's a great pleasure to be here in Ukraine and in this beautiful historic town of Genea. I'd like to thank Merck and their associates for helping me to get here. It's a very long way from Australia, but it's lovely to be here. I'm going to talk about a number of pharmacological, but also technological and also organisational issues about improving the IVF process for our patients. But I wanted to start with a bit of history. And I've been doing IVF or assisted conception for a long time, and when I began in the mid-1990s, the IVF or the assisted conception process was very complicated. We didn't know how to grow embryos in the laboratory very well, so we did a procedure which some in the audience might remember called GIFT via laparoscopy, where we provided ovarian stimulation. We did a laparoscopy to transfer the oocytes and the sperm. We had to put too many eggs in to try and make it work, so the drug protocols were very long. There was a general anaesthetic, more invasive procedure. It didn't work very well, and we had a problem of multiple pregnancies. Today, in 2017, we have much shorter, easier protocols like antagonist cycles. I do many of my egg collections without a full general anaesthetic. We know that we can grow embryos very well in the laboratory to blastocyst stage. And also, we have a lot of competition, because if I don't provide a good service, or if my patients don't like me, they can easily go to another IVF unit. So we have to constantly not only provide good laboratories, but we also have to provide good patient services. Now, in the 1990s, everything changed in a hurry, maybe over 2 or 3 years. We learned how to grow embryos much better in the laboratory. It was in our unit in Sydney that helped to the Cook company to develop the MINC incubators, M-I-N-C incubators. We developed better catheter systems. We learned how to grow embryos. And also in Australia in 1997, we introduced recombinant FSH. And so all of these technologies together suddenly doubled the chance from IVF compared to GIFT. But all of those technologies eventually become commodity. Every IVF unit can do those things as well, so your competitive advantage starts to lessen. Oops. Now, today in Australia, in Sydney, you may not know, we have a public reimbursement system where every patient gets a reasonably generous amount of money from the government to do their IVF, whether they go to an inexpensive program or whether they go to an expensive program. So our unit has a philosophy of trying to offer a high quality service with the best laboratory systems, the most individualised care, the best service. But of course what that means is that that will cost the patient more money compared to them going to a unit that might be inexpensive but might offer a lower quality service for the same amount of money coming back from the government. So we might ask, how does a unit that wants to provide a high quality service but inevitably might involve more cost, how do we introduce strategies to make them convinced that we are coming to the best place? And I would say that the answer to that is what people call patient-centeredness. What is patient-centeredness? It's providing care that is respectful of and responsive to individual patient preferences, needs and values, and ensuring that patient values guide all of our decisions. That was a definition from a United States institute. Now, sometimes people think that patient-centeredness means you have to do everything the patient asks for, even if it's crazy. You have to be completely disorganised because you're doing egg collections and embryo transfers all over the place. But that's not the case. It's possible to offer a service that is very business efficient, very quality controlled, very organised, and ultimately, if you apply all of those things, quite profitable. So in other words, patient-centeredness is not just doing the last thing that the last patient wants just because she read it on the internet. It is actually about providing the best quality service in an efficient, organised way. So all of good quality business processes are very patient-centred as well. So what I want to talk about today is go through a few different areas of the IVF process with a particular thought about patient-centeredness. I want to spend some time talking about ovarian stimulation and monitoring. I want to talk about what I would call the new IVF laboratory that is progressively emerging worldwide in the way we grow embryos. I want to talk about patient service that helps to reduce what we might call dropout, because dropout, patients discontinuing IVF is a big problem. And I want to finish by talking about communication and interaction and some quality assurance issues in an IVF process. So let's talk about ovarian stimulation and monitoring. And yes, part of this, I just want to get the next bit. I'm here with the sponsorship and the support of Merck, but I do want to say that I'm a very great believer in the use of the highest quality medications and the best delivery systems to administer those medications. So when we think about a drug, it's not only about the safety and the purity and the efficacy of the medication, it's also about the delivery system, the pen-based systems that we generally use. In terms of the quality of the drug, I think there's absolutely no doubt that recombinant FSH is a superior product, for example, compared to urinary products. That's been demonstrated now time and time again over 30 years. The original multi-centre trials in Europe compared 225 of a urinary product versus 150 IU of a recombinant product, and still found more efficacy in the lower dose. So we don't have to give high doses of recombinant FSH to make it work. And there are very many good reasons for why recombinant FSH is actually a better drug in terms of its efficacy. We know that because of the different sialic acid end pieces on the end of the protein, that confers superior activity at the FSH receptor. We know that recombinant FSH has much less batch-to-batch consistency, and to get the same response from the ovaries, we can give less medication. And because of the pen-based approach, because it's in a liquid form, it has a better delivery. So one of the things about having a highly purified product in a liquid form means that you can concentrate the liquid form and allow then for very, very accurate dosing. So this is the principle behind having a pen-based product that allows you to, particularly for younger patients with high ovarian reserve, allow to have much smaller increments in the way that the drug can be administered and dialed up via the pen. So this meeting coincides with the launch of the new pen from Merck with respect to delivery of gonal F, which I understand will be available in your units within the next month or two. And there are some specific features about that pen that allow for better delivery. So in terms of where the needle and how that is applied, they've raised the technology of that so it allows for recapping of the needle without getting needle stick injuries. The dialing of the pen is much better, so there's much less resistance. The old style pen is very hard to much harder to get it to the right place, whereas there is more resistance with the current pen, the new pen, sorry, that allows to dial up the correct dose. And when you see the pen there, I'm sure the Merck people will show it to you lots of times, but there is an easier diallage mechanism to read the dose, so there's much less confusion for the patients when it comes to applying the dose. And finally, one of the other problems of previous pens is it's been very hard to know when the patient has had the right dose or whether there are air bubbles, whereas the new delivery system of the new pen means that there aren't air bubbles, and when they hold it up there's a tiny drop that can be seen at the end of the needle that is clear that the pen has been primed properly. This particular device we've been using in Australia now for close to 2 years, so it's certainly proved to be, in all of those respects, a better product to use. And the last thing is, when the pen is actually delivered, it only takes 5 seconds rather than the old 10 seconds to actually deliver the medication. So Merck has undertaken a number of efficiency studies where this pen has been used before, and found that both the patients and the nursing staff who are teaching the patients how to use the new pen, that the vast majority of both patients and nurses find this new device much, much easier to use compared to former products or indeed alternative products. So in summary, it's a fairly simple process of basically capping the needle on, dialing the drug dose up, checking that there's the drop there, and introducing the pen delivery. So it's very simple. So as I said, I'm sure that the company will be able to demonstrate that to you. So that's about medication and delivery systems. In terms of protocols, I think there's now no doubt worldwide that if we can give simpler, easier protocols, in other words, antagonist protocols, that we can get the same response in terms of pregnancy rate compared to the old style long down regulation protocols. I think there is still sometimes a place for some women with endocrine problems who will benefit from long down regulation, but the vast majority of people can respond just as well in terms of pregnancy rates with less hyperstimulation through using antagonist protocols. And somewhere now around, must be now 5 years ago, we shifted in our unit from predominantly long down regulation to predominantly antagonist cycles without it upsetting the chance to get pregnant. Of course, one of the things that we all get a bit concerned about with moving to antagonist protocols is that it starts to become less organised, because if patients are starting at any day of the week, the risk is that they might need their oocyte collection at any day of the week, compared to a much more protocoled use with long down regulation. So I'm sure you're familiar with a number of approaches that people have used to try and program antagonist cycles to try and minimise the amount of weekend work that can be done. And the various ways that they have been described. Sorry, can I go backwards? It keeps jumping ahead. Yep. So the mechanisms that have been described are, one is to pre-treat with the pill. One of the problems of that is that it may well lead to an endometrial development lag. So people have wondered whether that might lower pregnancy rates. People have talked about flexible starts, but if you delay your start or you delay your trigger, that might lower the chance. My own view, and I think it's backed up with studies, that if you do want to do programming, some pre-treatment with with simple estradiol, valerate, or Progonova is the brand in Australia. That's the way I would run many of my cycles, that patients commence estradiol valerate 2 milligrams twice a day from about 5 days before their period. They have their period, they stay on the estradiol for a few more days, and we can then regulate a similar start day for the vast majority of people. So in my unit, that's the way I would run most of my IVF cycles, and I think that's been backed up by randomised trials without it lowering the pregnancy rate. And a reminder that from a patient-centred approach, having an organised system is good for the patients as well as good for the unit. One of the other things we know is that we don't have to get multiple oocytes to raise the pregnancy rate. There are now several large studies showing that the ideal number of eggs to collect is maybe somewhere in the region of 12 to 14, and anywhere beyond about 8 mature oocytes, I'm fairly happy with that response, because in my experience, 8 to 14 oocytes will often lead to in the region of 2 to 4 high-quality blastocysts at day 5. And we know that getting higher numbers of eggs doesn't necessarily improve the number of embryos or improve the pregnancy rate, as this very large study some years ago now from the United Kingdom showed. One of the things now that in my unit where we do increasing numbers of cycles of PGS or PGD, one of the questions that we have been asking is it a sensible thing to give more and more gonadotrophin stimulation, because if the patient wants PGS, maybe we should be getting more eggs, and maybe therefore that will lead to more embryos. And so this was a study that my colleague and I presented at one of the Asian meetings a few years ago, which said that for any given age or for any given level of AMH, if we increase the FSH dose a small amount to try and get a few more eggs, is that better or worse than trying to give a much higher dose of gonadotrophin for any particular level of AMH? In other words, because we can now give an agonist trigger and freeze all of the embryos, is it good to just give high doses of the drugs? But interestingly, what we found was that giving too high a dose of drug actually usually meant that we were biopsying on average 1 less blastocyst at day 5 compared to if we just gave a modest increase in the dose. We didn't change the aneuploidy rate of the embryo, but we did change how many embryos were good quality from an appearance, from a morphology perspective. So giving very high doses of FSH doesn't always help us, but maybe giving a small increase for treatments like PGS are valuable. I think it's quite clear in large studies that giving more drug doesn't necessarily change the aneuploidy rate of the embryos, but there is some emerging data now within PGS that maybe we are changing things like the morphology of the embryos and the mosaicism rate of the embryos. The next slide. Yep. As you know, mosaicism, if you undertake PGS, is an increasing problem worldwide because our DNA testing platforms have become more and more accurate. We are now picking up very minor changes in mosaicism because we are sampling a number of trophectoderm cells from the blastocyst. And we don't know what that means. We don't know if it's just part of nature. We don't know if it's an effect of ovarian stimulation. We don't know if it's an effect of the laboratory. People are starting to question whether we can use mosaicism as a quality assurance tool to determine whether our stimulation dosing, our timing of egg collection and our laboratory systems are the highest quality. But one thing is clear, in my data it seems to be that giving too high a dose of drug or doing something in your system incorrectly may increase your mosaicism rate, and I think that's been shown from around the world. Just finally, maybe not now, but not very far away, we will have much more simpler monitoring systems for patients. Maybe we can be doing remote finger prick testing for estradiol levels, plugging the machine into a smartphone with the information sent remotely to the IVF unit, or even ultrasound that can plug into a smartphone. So we have all sorts of interesting monitoring technologies maybe into the future. Let's talk a little bit more about some IVF processes within the laboratory now. And this is, I'm very proud of the fact that my company, Genea, has a worldwide relationship with the Merck company, because in Australia we have developed some biotechnology products in IVF that are now being distributed progressively around the world. Not yet in this region yet, but if you are going to Escheri, you will see many of these products as under this banner of Merck and our company called Genea Biomedics. One of those now is increasingly, we know it's a good quality assurance mechanism to have automatic ID, not only ID patients from a manual perspective, but also from an automated perspective. One of the best ways you can be patient-centred is to make sure that there are no errors when it comes to identification. If there is an impact of the incubation process upon embryo quality and on mosaicism rates, I think there is increasing tendency now to disturb the embryos less. So this particular incubation system that we use and is now available in parts of the world has, it's like the benchtop incubator systems, but it's individual patient chambered, where each patient's embryos are only in one chamber. Every single embryo is undergoing time-lapse photography, not just a small proportion. And so a combination of single-stage media all the way to day 5 blastocyst in combination with time-lapse morphometry as well as allows for a higher grade of embryos and much better proportion of embryos moving on to blastocyst. And in fact, using those time-lapse images as a service model, we've just introduced a concept now where we've developed a secure patient portal via our smartphone apps where patients can log in and view their embryos developing via the time-lapse system. They don't get to look at them every 5 minutes in the middle of the night, but they do get to see images and download images of their embryos after a conversation with the scientist on day 1, day 3 and day 5. And I think that's going to be proved to be very popular with our patients. And finally, the other aspect of making the IVF laboratory work better is through automated vitrification. We know that embryo vitrification is clearly not harming embryos. The big problem with the current vitrification systems is that it's very, very labour dependent. It's the quality of the scientists and their expertise will change the results of vitrification. So we've developed an automated vitrification machine called Gavi, where the embryos are placed in pods, they're put into the machine, and an automated system introduces all the cryoprotectants, seals the pod with the embryo in it, and then it simply dunks the embryo into liquid nitrogen for vitrification. So this process eliminates the labour variability depending on the expertise of the laboratory. And I think this is going to be very useful because it doesn't matter where your IVF unit is in the world, whether it's here, whether it's in Western Europe, the United States, Australia, the incubation systems and the freezing systems, the vitrification systems are going to give us pretty well exactly the same quality assurance no matter where we are. And I don't need to maybe tell you now, but there's no doubt that vitrification of embryos gives us the same live birth pregnancy rate. This is a study we published in Fertility and Sterility a few years ago, where the results from fresh or frozen embryos are the same. And you'll be familiar that several studies now are demonstrating that the best quality results we get come from frozen thawed embryos replaced in women's more natural cycles. Maybe we don't have to freeze everybody's embryos every single time just yet, but certainly if there's any concern about overstimulation, we now know that we can safely give an agonist trigger and vitrify embryos without harming them. Oops, let's go next one. Yep. Finally, I don't have the time today to talk about PGS. I'm still not convinced whether PGS is necessary for every single patient. I think it is a very useful tool if a patient gets a high number of embryos, because we will be able to then be more cost effective and more time effective for them by only focusing on the embryos to transfer that are later normal, even if it doesn't change the chance from the original oocyte collection. So we're doing a number of cost-benefit analyses in our unit to determine the true role of PGS. I think it does have a very important role, but I'm not yet convinced that it's a universal role. Just want to talk about just a couple of other things in a few more slides, not for very long. One of the ways we can improve our patient experience and ultimately our results is by trying to ensure that people don't drop out and stop their IVF before there was a reasonable chance of them having success. Because if we want to define success in IVF as the chance of an individual woman having a baby, then that chance will be lower if they stop after only one attempt or only after 2 attempts. We are ultimately lowering that overall definition of success. And this was a study I did with our internal data some years ago, where the light purple bars represent the actual accumulating chance of getting pregnant over 3 egg collections, and that if we reduced the dropout by 5%, we would push those bars up a little bit, and if we were able to reduce dropout by 100%, we would get the results seen in the yellow bars. So this demonstrates that having a good service, nursing interaction, counselling, medical interaction process to reduce dropout actually improves your pregnancy rate, even maybe beyond your laboratory. It's a complex reason for why patients drop out, but interestingly, in most parts of the world, it's not because of money. If there is a reasonable good prospect of them getting pregnant again by trying another attempt, they will do it, but it's very important that we provide mechanisms that give them the psychological support, the counselling support, the medical feedback, and the scientific feedback. Just largely some things about how we might run ourselves from a business perspective. There's no doubt that if we can, it's interesting that if your waiting room looks very good, the patients have already decided that your laboratory is very good. So it's clear that it's important that we provide a good quality service even from the moment patients walk through the front door. Having a site where you can easily, your patients can get to you is very important. And so there are lots of aspects if you're getting the chance to design a new IVF unit or to upgrade where you are, to have some thoughts about, it's not only about all the good laboratory stuff, it's also about the good overall perspectives that we provide. Our unit certainly believes a lot in communication with patients, both at the medical level. If I have a person who has an unsuccessful cycle and I need to communicate with them, I don't talk to them every 5 minutes, but rather than making them wait a long time to come back for a consultation, sometimes a very quick telephone conversation allows them to start again without too much delay, and that helps you as well as helps the patient. Having nurses with the confidence and the training and the expertise to be not only good at their reproductive medicine, but to be good counsellors as well, takes a lot of effort off the doctor. And we also believe, as I said before, that our scientists should be regularly conversing with our patients on the telephone to let them know how embryos are going. So there's a whole variety of verbal interactions that we can use that helps to keep a patient-centred approach. There's also the concept of online interaction. I do a little bit of this, but I don't want the patients to have control of my entire life in terms of social media, but in terms of things like Twitter, you can often let them know that you're giving a talk in the Ukraine or that some latest study that might have been developed. I think those things are very useful. As I said, the online portals are very useful, and there are various online ways that we can communicate, because I think we have to somehow provide some pushback against the chat rooms, because the patient chat rooms is where a whole lot of non-science is evolving and a whole lot of things get turned into truths that aren't really truths. And I think we have to do our bit in the online space to push back against some of the the stuff that we know is crazy stuff. And just finally, the best way to be a business approached unit is to have a very good quality assurance process, good human resourcing processes, and this is true not only within your own unit. In other words, you don't want to have your scientists scared of you. You want to have an open disclosure-based unit, because if you have a fear-based human resource strategy, when your scientists make a mistake, they won't tell the doctor, and that is no good for you, the patient, or for the business. So open disclosure, sitting down with patients and talking to them when something happens and explaining to them means you can turn a potential lawsuit into someone who is actually becomes your greatest friend by trying to get them back to the space where they were through honesty and good discussion. At a more national level, I think that it's very important for us as societies to develop the best kind of quality assurance mechanisms we can and the best auditing mechanisms. In Australia, we've worked very hard to have a self-regulated society, because if you have a self-regulated society with proper accreditations and result publishing, that will stop the government from coming in and introducing a law which tells you what you can do and what you can't do. And when governments introduce laws to tell you what you can do and what you can't do, we all know that politicians get that wrong regularly because they don't understand the process. So in conclusion, whilst the IVF process remains complex, procedures like ovarian stimulation and technologies in the lab are starting to become much better developed to allow us collectively make life easier for the patient, the process more tolerable, and also the new laboratory processes are making the interactions better and the chance to get pregnant per cycle better. I think it's very important that we try and put all of that together to make sure that we're helping the people that are going to be helped as fast as possible and stopping them from dropping out. And so really, if we have this concept of patient-centeredness, if we implement it appropriately, it can actually provide us with competitive advantage. So on that note, thank you very much. From a long, long way away on the other side of the world. If you're ever in Australia and in Sydney, you're very welcome to come and visit. Thank you very much.
Thank you.